Welcome to the ischemic heart disease section of the Mat 2 cardiovascular course. Coronary artery disease is the most common disease we see in daily cardiology clinical practice. Over the next two lectures, we will go over the clinical manifestations and management of these patients. We will also have a dedicated TBL session later on to discuss these concepts further. This is a schematic which shows the natural progression of atherosclerosis in human beings. On the left side, you see a cross-section of a normal, healthy coronary artery. With aging and with accumulation of risk factors such as smoking, diabetes, hypertension, or hypercholesterolemia, we start seeing deposition of cholesterol in the wall of the coronary artery that ultimately formulates what we call plaques. As these plaques increase in their size and in the percentage of stenosis, they will reach a critical percent stenosis, which usually corresponds to 70% obstruction of the coronary artery, at which point these patients start complaining of chest pain or angina. So in this lecture, we're going to focus on patients who have stable coronary plaques causing 70% or more obstruction in the coronary artery. We will go over the clinical presentations of these patients. How do they present to us in the clinic or in the emergency department? The diagnostic tests that we use in their evaluation, and the most common medications and interventions that we use in their treatment. Let's start with the clinical presentation. Angina or chest pain is the cardinal manifestation of patients with coronary artery disease. Patients usually describe their chest pain as a substernal chest discomfort, as heaviness, tightness, or burning. It might radiate to the left arm or back. In rare presentations, patients might complain of interscapular back pain, jaw pain, or epigastric pain. But we always need to remember that not all chest pains are necessarily cardiac in origin. The thorax has multiple other organs that might cause pain, and the differential of chest pain includes many entities. Some of these are listed on this slide, which include musculoskeletal chest pain, aortic dissection, pulmonary emboli, perforating peptic ulcer disease, pericarditis. Gastroesophageal reflux disease might also cause chest pain, and diseases in the lungs such as pneumothorax might also cause chest pain. There are several clinical characteristics that we use to differentiate between a typical angina secondary to obstructive coronary artery disease from other causes of chest pain or non-cardiac chest pain. In typical angina, patients usually complain of substernal chest discomfort with a characteristic quality, as we said, burning, tightness, or heaviness. This pain is usually provoked by exertion and relieved by rest or by the intake of nitroglycerin. So if the patient has these three characteristics, then this is most probably typical angina that is secondary to obstructive coronary artery disease. If the patient has only two of these characteristics, then we call it atypical angina. And if the patient has only one of these characteristics, then this is non-cardiac chest pain and most probably not due to obstructive coronary artery disease. To help us further in differentiating between typical angina and non-cardiac chest pain, Diamond and Forrester derived data from a large cohort of patients that estimate the probability of coronary artery disease in symptomatic patients according to their age, gender, and type of chest pain. For example, as you see in this table, if you have a 60-year-old man complaining of typical angina, the probability that this patient has obstructive coronary artery disease is 94%. Whereas if you have a 45-year-old woman complaining of atypical angina, the probability of having coronary artery disease goes down to 22%. In clinical practice, not only we need to differentiate between angina secondary to coronary artery disease versus other kinds of chest pain, but we also have to assess the severity of angina, which usually correlates with the extent and severity of coronary artery disease. Angina is usually classified into 4 classes. In class 1, patients complain of no angina with ordinary physical activity. In class 2, they start having early onset limitation of ordinary activity, and they might have chest pain on walking more than 2 blocks or climbing stairs rapidly. In class 3, they have marked limitation of ordinary activity, and in class 4, these patients might start having chest pain during rest. And in this category, in class 4 angina, we start seeing overlap with another entity, what we call unstable angina, that we will discuss in our next lecture. In the next part of this lecture, we will go over the different types of diagnostic tests that we use in the evaluation of patients with suspected coronary artery disease. This slide shows the relationship between coronary blood flow and percent obstruction or stenosis in the coronary arteries. You see that for a long range of percent stenosis, the coronary blood flow is maintained the same through a process that we call coronary autoregulation. Only when the obstruction is more than 90%, we start seeing a reduction in the coronary blood flow at rest. So if we have a patient who has a 70% obstruction in his coronary arteries, the coronary blood flow at rest is going to be the same, and the only way to uncover myocardial ischemia would be to provoke it with exercise. So what we do with exercise, we increase the heart rate, we increase the myocardial contractility. This is going to increase the oxygen demand, and this will lead to a oxygen supply oxygen demand mismatch if the patient have an obstruction in his coronary arteries. This will lead to myocardial ischemia, which might manifest in different ways. It can manifest on changes on an electrocardiogram, or perfusion abnormalities on a nuclear scan, or contraction abnormalities on echocardiography. And we will go over these diagnostic tests in the next few slides. This is what you see in a typical treadmill or stress ECG test in a patient who has significant obstructive coronary artery disease. The panel on the upper page shows a normal resting ECG. As the patient starts exercising, we start seeing ST segment depressions, as noted in the second panel and as shown in the black arrows. As the patient exercises more and more, the ST segment depression increases, and then when he or she stops, the XT segment starts to normalize in the recovery phase. These EKG changes on the stress ECG test don't tell us only whether the patient has ischemia or not, but they can also give us an idea about the extent and severity of myocardial ischemia. There are markers on a stress ECG test that will tell us that this patient might have extensive or severe myocardial ischemia. These are shown in this slide. Early appearance of ST segment depressions during exercise is a marker of severe myocardial ischemia reflecting severe or extensive myocardial disease. If a patient develops ST segment depressions after 1 minute of exercise, this is a marker of more severe ischemia than somebody who develops ST segment changes after 5 minutes of exercise. The amount of ST segment depression is also an important marker of the severity of myocardial ischemia, and the time it takes to normalize the ST segment changes after recovery is also an important marker of the extent of myocardial ischemia. The longer time it takes for the ST segment changes to recover, to normalize in recovery, this is the sign of more extensive myocardial ischemia. Cardiac nuclear imaging is another frequently ordered test for the assessment of patients with suspected coronary artery disease. Here, the added advantage is that with nuclear imaging, we have a direct assessment of myocardial ischemia by intravenous injection of radioactive material during exercise and at rest, and the uptake of this radioactive tracer by the myocardium is usually proportional to the blood flow. This is an example of the nuclear images we obtain in patients who undergo stress nuclear imaging and has significant obstructive coronary artery disease. In the upper panel, you see a cross-section of the myocardium during stress, and in the lower panel, you see a cross-section during rest. Yellow is the radioactive material uptake by the myocardium. You can clearly see that during stress, there is an area that's shown by the red arrow which has decreased uptake of the radioactive material, whereas this area becomes normal at rest. This indicates that there is a myocardial ischemia in that territory, which reflects an obstruction in the coronary artery supplying that zone. The added advantage of nuclear imaging is that we can quantify the extent of myocardial ischemia, as you see on the panel on the right side. For example, in this patient, we estimate that the perfusion defect size was 20% of the left ventricle. The perfusion defect size carries very important prognostic information that was shown in the large COURAGE trial, in which they took a large number of patients with coronary artery disease who underwent cardiac nuclear imaging, and they followed them up for 5 years. And they noted that the rate of death or myocardial infarction is proportional to the extent of perfusion defect that is noted on nuclear imaging. So in people who have a normal scan or a 0% perfusion defect, the rate of death or myocardial infarction was 0%, whereas the rate of death or MI increased to 39% in those who have a perfusion defect more than 10% of the left ventricle. Exercise echocardiography is the third common type of test that we use in the assessment of patients with coronary artery disease. The principle here is the same like nuclear imaging, but rather than looking at perfusion, we look at wall motions as detected by ultrasound. So the patient is exercised, and if you have significant coronary artery disease, the myocardial segment that's supplied by that artery will become ischemic, its contractility will decrease, and this will be detected on ultrasound as we use in echocardiography. The final test in the evaluation of patients with coronary artery disease, and the gold standard test, is coronary angiography. This is an invasive test in which we insert a catheter inside the body and we inject a special contrast that will opacify all coronary arteries, and they will delineate any pathology that we see in the coronary arteries in the lumen of these arteries, as you see in this patient, where there is a significant obstruction, almost a 90% obstruction in one of the coronary arteries that is shown in the red. In the third and last part of this lecture, we will discuss the treatment of patients with coronary artery disease with various medications and interventions. When we talk about stable coronary artery disease, there are two targets of therapy. On one side, we want to prevent the development and the consequences of myocardial ischemia, and this is what we do by the use of anti-ischemic medications. The other target of therapy, which is as important, is to prevent the progression of patients with stable coronary artery disease into acute myocardial infarction or acute coronary syndromes, and this is where we use vasculoprotective medication. Let's start with anti-anginal or anti-ischemic medical therapy. The objective of the treatment here is to improve the oxygen supply-demand mismatch. There are 4 determinants of oxygen demand or consumption that we need to remember: preload, myocardial contractility, heart rate, and afterload. There are 3 classes of anti-anginal medications that we use in common practice: beta blockers, nitrates, and calcium channel blockers. Let's see how each of these classes work on the 4 determinants of oxygen consumption. To start with beta blockers have no effect on preload, but they do decrease myocardial contractility, they decrease the heart rate, and they decrease the afterload, and this is how they improve the supply-demand mismatch. Nitrates are vasodilators. They decrease the preload by dilating veins. They also decrease the afterload by dilating arteries. They have no impact on myocardial contractility or heart rate. Calcium channel blockers are similar to beta blockers. They have no effect on preload, but they decrease myocardial contractility, they decrease the heart rate, and they also decrease the afterload. This slide shows how these basic concepts in the treatment of patients with coronary artery disease with anti-ischemic medication, how do these concepts translate into clinical practice? You see here on the y-axis the time to onset of angina during exercise, and on the x-axis increasing doses of nitrates. You note that with increased doses of nitrates, the exercise endurance of patients increases, and they will exercise more and more before they start complaining of angina. Nitrates, beta blockers, and calcium channel blockers are traditional anti-ischemic medications that prevent the development of ischemia by their effect on heart rate, afterload, preload, and contractility, and improving the oxygen supply-demand mismatch. Over the recent years, a new class of medication was introduced that prevent the consequences of myocardial ischemia after it happens. Ranolazine or Ranexa is one of these new recent anti-anginal medications. Its molecular structure is shown here. It is an inhibitor of the late cardiac sodium current. The mechanism of action of ranolazine at the cellular level is shown on this slide. Myocardial ischemia leads to activation of the sodium channel or the inward sodium current, which brings sodium ions from outside of the cell to its inside. As the sodium concentration inside the cell increases, this activates the sodium-calcium exchanger, which takes sodium outside the cell and brings calcium inside the cell, leading to calcium overload. Calcium overload is known to have a very important detrimental effect on myocardial contractility. So by blocking the sodium channel, ranolazine will prevent calcium overload and its detrimental effect in myocardial ischemia. In summary, myocardial ischemia will increase the late sodium current. This will lead to sodium overload inside the cell. By activating the sodium-calcium channel exchanger, this will lead to calcium overload, which have several negative effects on the myocardium, including arrhythmias, decreased contractility, and impaired diastolic function, as well as impairment in the oxygen supply and demand regulation. So when ranolazine blocks the late sodium current, it will prevent all these negative cascade and prevents the consequences of myocardial ischemia. Similar to what we have seen with the traditional medications of beta blockers, nitrates, and calcium channel blockers, ranolazine has been shown and proven to decrease the number of angina attacks in patients with obstructive coronary artery disease, as you see in this slide. In patients who were taking ranolazine 1500 milligrams, the number of attacks per week decreased from 3.3 to 2.5, and this further decreased to 2.1 with an increased dose of ranolazine to 2000 milligrams per day. Also similar to what we've seen with the other anti-ischemic medications, the use of ranolazine will increase the exercise duration and improve the exercise endurance of patients. It will also increase the time before they start complaining of chest pain, and it also increase the time to 1 millimeter ST segment depression on a standard stress ECG test. We so far have covered anti-ischemic medications that prevent the development of myocardial ischemia or its consequences, but these medications have no direct effect on plaque morphology or structure. The other class of medications that we use in the treatment of patients with coronary artery disease are what we call vasculoprotective medications. There are two classes of medications that fall under this category. The first one are antiplatelet medications such as aspirin or other medications such as clopidogrel that prevent thrombus formation. The other important class of medications are statins or lipid-lowering therapy that have a direct effect on plaque morphology to stabilize it and preventing it from rupture that leads to acute myocardial infarction or acute coronary syndromes. This slide illustrates the case of a patient that we saw several years ago in the clinic. He presented with a stable angina with recurrent episodes of chest pain on exertion. He was started on medical therapy with aspirin, beta blockers, and nitrates, but he persisted to have chest pain after several months of treatment. So a coronary angiogram was done, which is shown on the left upper panel, that shows a very tight stenosis in his right coronary artery that is shown by the white arrow. He also underwent a nuclear scan which showed a perfusion defect in the inferior wall, which is reversible and ischemic as shown in the white arrows. So what do we do in these patients that fail medical therapy? These are the cases in which we have to resort to what we call mechanical revascularization or mechanical intervention. One of these mechanical interventions is coronary angioplasty or percutaneous coronary interventions. This is an invasive procedure in which we take a catheter from a peripheral artery, such as the radial artery or the femoral artery, and we take a catheter all the way up to the coronary arteries. Then we introduce a balloon that opens the coronary stenosis, and after opening the stenosis with a balloon, a coronary stent made of special metallic mesh is placed in that position to prevent the vessel from occluding again. This is exactly what we did in this patient, and the panel that you see in the middle here shows the stent being deployed, and after the deployment of the stent, the coronary artery returned back to normal with no residual stenosis, and a repeat nuclear scan showed complete resolution of the ischemic defect in the inferior wall. Coronary angioplasty and stent deployment are very commonly used now in the management of patients with ischemic heart disease. But in some cases, such as the patient you show in this slide, the coronary artery disease is very diffuse, and coronary angioplasty and stenting might not be feasible. These are the patients that we refer for another form of myocardial revascularization or intervention, namely coronary artery bypass surgery. This slide illustrates the basic concept of coronary artery bypass surgery, where bypass grafts are placed from the aorta to the coronary arteries distal to the blockage, thus restoring normal blood flow and abolishing myocardial ischemia. In conclusion, we have covered in this lecture the management of patients with stable coronary artery disease, in which you have a stable plaque causing an obstruction of 70% or more in one of the coronary arteries. We went over the clinical presentation of these patients, the diagnostic tests that are used in their evaluation, and their treatment with either medical therapy or mechanical interventions such as coronary angioplasty or coronary artery bypass surgery. In the next lecture, we will go over the management of patients with acute myocardial infarction or acute coronary syndromes, in which we have acute plaque rupture and thrombus formation. Thank you.